Hi, my name is Alexis Gilmore, and I'll be presenting my quantitative critique on the article Critical Care Nurses, Pain Assessment and Management Practices, a survey completed in Canada, and the reference for the article is available on the bottom of the first slide. The research problem and purpose. The problem is identified as increased or mismanaged pain can lead to increased hospital stay time, as well as an increased need for mechanical ventilation. And the purpose of the study is to document nurses' knowledge and perceptions of pain assessment, tools, and management amongst Canadian intensive care unit nurses. The research objectives are fairly long. There are two, and I'll go ahead and read them to you. The first is to compare the proportion of nurses who utilize patient self-report tools with the proportion utilizing behavioral pain assessment tools for those patients who are able and unable to communicate. And the second objective is to determine factors associated with the use of behavioral tools, behavioral and physiological indicators of pain, the awareness of local and international guidelines related to pain, the content of education on pain, and the pain communication and management process. There was no model or framework identified for the study, and the design utilized was a descriptive design utilizing survey distribution. The sample included 16,036 nurses from Canadian ICUs. 16% of them were from Ontario, 21% were from Alberta, Quebec, and British Columbia, and 52% of the nurses were from all of the other provinces. Some additional points about their demographics involve that many of the nurses surveyed were nurses on their units for over 10 years. Many of them are full-time. Most of them had a bachelor's or diploma degree, and most of the hospitals were university affiliated. The inclusion criteria involved nurses working on adult intensive care units, and the exclusion criteria included nurses who worked on pediatric intensive care units. They were excluded because they utilized different forms of pain assessment and management, as well as any nurses who were incorrectly identified as ICU nurses. If those surveys were returned, they were also excluded. The variables involve three research variables. The first is nurses using or not using pain assessment tools. The second is patients who are able or unable to communicate. And the third research variable is nurses' education on pain assessment tools and the current recommendations. The ethical components. The study was approved by the University of Toronto, Ontario by their Research Ethics Committee, and confidentiality agreements were completed by the researchers as they contacted local nurses associations to gain nurses' contact information. However, a piece that's lacking is that the study does not explicitly state that nurses were able to fill out an informed consent prior to responding to the survey. The data collection involved a stratified disproportionate random sampling method. The survey was sent out in 3 rounds with 2 weeks between each round, and 2 email reminders were sent out to those nurses in which the researchers had contact information for. The nurses' contact information was gathered from nurses' associations from the 12 provinces and territories involved in the study. In 5 of those provinces, the researchers managed the distribution and collection of the surveys. In 6 of the provinces, the Nurses Association managed the distribution collection, and in 1 of those provinces, a nurse from an ICU managed the distribution of collection on her ICU as well as on another intensive care unit. The statistical methods involved a survey test-retest reliability utilizing 10 ICU nurses who helped to develop the survey, and they were not involved in the initial pilot test. The initial pilot test took place in 1 hospital on 5 different ICUs, and the test-retest reliability was evaluated using the Cohen-K statistic, and any value greater than 0.4 was considered to be a moderate to good agreement. Additionally, the information was broken down into categories utilizing a 95% confidence interval, and those categories involved never, seldom, sometimes, often, and routinely. And those responses related to how often nurses utilized different forms of pain assessment, behavioral assessment, and management tools on the unit. So any response that included never, seldom, or sometimes was considered to be used less than 50% of the time on the unit, and often and routinely were considered to be used more than 50% of time on the unit. The results included a 24% response rate, only yielding 802 surveys, which is fairly low. The results also found that almost 50% of the nurses sought out to provide an analgesic for pain prior to going into a deeper pain assessment, and fewer nurses utilized pain assessment tools for patients who were unable to communicate versus those who were able to communicate. Additionally, fewer number of nurses utilize behavioral pain assessment tools in comparison to self-report tools, so those two statistics go hand in hand. Additionally, 92% of the nurses found that physiological symptoms of pain, such as changes in heart rate and blood pressure, were good indicators of pain, and only 29% had read the updated guidelines on pain assessment and recommendations. And fewer nurses found that pain was an important assessment for medical patients and compared to surgical patients. The limitations of the study involved a selection bias, a lack of generalizability, and possible bias related to the respondents, as the researchers suggested that maybe those nurses who were more interested in pain assessment and management were those who responded to the study. The implications for practice involve the need for more consistent tools to evaluate and document pain assessment in both patients who are able and unable to communicate, and also an increased need for education for our nurses to make sure they're staying up to date on the current recommendations and guidelines for pain assessment and management. In conclusion, it's important for nurses to be adequately assessing, documenting, and managing pain of patients who are able and unable to communicate on intensive care units to help decrease the hospital stay and decrease the risk for mechanical ventilation. Thank you.